Hello, everyone. Thank you all for joining, and thanks, Casey, for highlighting all the great things that are happening with NOAA. And this is the Doctors with Albinism group. And so, just to tell you a little bit about us, we are a global community of physicians living with albinism, some in training, some already relatively senior, and you'll hear examples of that in a moment. And we really formed a couple of years ago to support each other, develop friendships, mentoring, and it's been a great group. And one of the things that we really wanted to do is this kind of outreach. And so this is our point of doing this. Um, we're here to sort of share a little bit of our journeys and our experience. And I think out of that, we hope that you'll be a little bit inspired about the possibilities of being a doctor with albinism, that you'll sort of see examples of how people have been resilient and adaptive to some of the visual challenges, and we'll talk about that. I think we'll also acknowledge up front, um, yeah, it ain't easy. Just becoming a doctor, even without albinism, is not easy. It's very competitive and all of that. We're going to really focus on the intersection of doctors with albinism. What we won't do, though, because I think there was some question, we're not here to give medical advice for any sort of clinical situation. So please, not those kinds of questions. So what you'll see that our panelists are really a diverse group of individuals. At different levels of their career. So you'll get that perspective, different geographies, different countries, and different specialties within medicine that we represent. So, what I'm going to do next is ask each person to tell a little bit about themselves to get started. So, maybe Jonathan, can we start with you?
Yeah. So good evening, everyone, or good morning, wherever you are. My name is Jonathan Drossil. I am currently in between my third and fourth years of medical school at the Icahn School of Medicine at Mount Sinai in New York. And I'm currently on a gap year doing a Master's of Public Health um, at Johns Hopkins University in Baltimore, Maryland. And yeah, I'm really excited to be here. Join this group, Doctors with Albinism, because I wanted to feel less fear around living with my condition, being in medicine, while experiencing albinism and the visual challenges that comes with it, and honestly, like to also address some of the shame that I had around the condition, and kind of it's been a really great community. So excited to be here and answer questions.
Great, thanks. Jack.
So, hi everyone. I'm Jack. I'm a cardiology fellow in Montreal, Canada, at McGill University, and I'm hoping to share tonight some of the insights that I've gained so far through now. This is now my eighth year of medical training, and lots of challenges that I've faced trying to prove that I am as good, or even I don't want to be arrogant, but even better than some of my colleagues as well, in spite of my very bad eyesight and the fact that I have managed to achieve a lot, in spite of the challenges, often coming up with workarounds and various optical and non-optical strategies to enable me to get through and to really thrive, and to show other people that yes, it's possible. Just because your eyesight is terrible doesn't mean that you can't achieve what you want.
Great. Megan.
Hi, everyone. My name is Megan Duffy. I am an infectious diseases specialist living in Houston, Texas. Um, I did my medical training in Milwaukee, and then I did a combined internal medicine and pediatrics residency in Indiana, and then I did my infectious diseases fellowship in Houston. A common thread that you'll find here is that medical training is really long and you end up kind of moving all around. So I was fortunate to get really good training, and now I'm kind of in my early career, kind of settling into what I want my long-term career to be like. And so very excited to be here.
Torre.
Good evening, everyone, but good morning to everyone as I'm in calling and I'm talking from Western Australia, and it's 9 in the morning. And I am an Italian Australian child and adolescent psychiatrist. I've been working in the field of child and adolescent psychiatry since 40 years ago, when I finished my specialist training, and I did my medical degree between 75 and 81. I also had the pleasure to work in 3 countries and 2 continents, because I worked in Italy, then in England for nearly 8 to 10 years, and then now 13 years I've been working in Australia in rural and remote, but also in the main city. And now currently I'm the medical director of a youth mental health service and eating disorder service. I am keen to share my knowledge, my experience, but more important, to support all young people, and not young, anyone who want to embark, who has albinism, who want to embark in the profession of being a doctor, because I believe that we can offer a lot, and all of us are fantastic doctors, and we have nothing less than anyone else. It's a challenge, as someone said, to go through medicine, but at the same time, I can say that majority of us thrive and actually are a good complement to all the disciplines. So, and I strongly support the inclusion of people with any disability in the medical profession.
And as I said, I'm Bob Gabbay. I'm an endocrinologist, which is a hormone specialist by training. I'm at Harvard Medical School, and so I'm in Boston, and I've had a number of leadership roles along with clinical practice and doing research over the years. I led the Joslin Diabetes Center, which was a Harvard Diabetes Center, and then about a year ago stepped down as the Chief Scientific and Medical Officer of the American Diabetes Association. And really, I think, when I was coming through in medicine, I didn't know anyone else that was with albinism, and so it's so nice to be with this group and to share with you our experiences. And again, I hope it inspires you to think about medicine and the possibility that may not have been presented to you in the past. So let's jump right in, and I'm going to ask each of you the same question. And so we said medicine is not easy, and a career in that is not easy. What's sort of the biggest professional challenge related to albinism that you've had, and how have you overcome it? Because obviously all of you are successful in the work that you've done. Um, and and so, Jonathan, you're earlier in your career as a medical student, and maybe you're closest to some of the initial challenges. Why don't you share for starts?
Yeah. Yeah, thank you so much for the question. Yeah, I think just a couple of things come to mind. Um, One, I think, is the engagement while you're on rounds, and rounds of these process, where the team is either at a computer station or walking around the hospital, and we're discussing the patients that are on our list. and trying to discuss what's the next step forward, how we're going to manage the patient for today, are they going to be released from the hospital, things like that. And I think that process of following along, whether it is reading the EKG strip on the computer screen, or certain imaging studies, or even like reading the notes written by other colleagues, there's kind of this process that happens during rounds where maybe one person is leading the charge with the movement around a particular patient's chart. And I always found it really difficult to follow along with that person with their computer screen, given the fact that I wasn't able to be close enough to that screen, and I guess experience the information in a way that was accessible for me. And the ways that I've kind of navigated that situation has really been through my iPad. Fortunately, the electronic medical record system that my institution uses, there's an iPad version, a phone version, and really that's how I've kept up, with discussion on different lab values for the patient, or imaging studies. It doesn't have everything, which can be difficult, and those are the moments where I have to speak up for myself. So take, for example, an EKG strip chart. It's a grid of boxes that then tell us about the heart's electrical activity, and sometimes having to understand the distance between one peak and the other can be a little difficult for me. And yeah, I think that in those moments I've had to either say I'm going to need to be closer to the screen, and we can definitely talk about those types of conversations and kind of the things that brings up for you on an individual basis. And I think moving forward, actually going into my fourth year, I'm going to be in the process of getting some telescopic lenses to help me with that as well. But I'll leave it at that. There's definitely one more thing to deal with, like surgery and suturing, but if we have time, I'll touch on that.
Okay, and just so that people understand, so you when they're walking around with the computer moving from room to room, you have an iPad that's mirroring that you allows you to zoom in and be able to see what you need to see.
Exactly, yeah. And it might require me to ask the team, kind of like which patient, rather, which physician's note or which provider's note you're looking at, so that I can easily follow along. Because on my iPad, I'm able to zoom in and read the chart. Because honestly, the default setting in terms of font size for many of the electronic medical records is quite small, and that definitely poses a challenge, when I think the expectation is that you're supposed to be this like seamless person, able to just take in all the information that's being thrown at you. One, already a difficult task as a medical student, because you're new to the information and you're trying to do your best to gather all the pieces to the puzzle. And then two, not being able to actually take in the information can pose some challenges for sure. So yeah, having the iPad with me has definitely helped, especially for images. Definitely.
Great. Jack,
Yeah.
sort of the
So I'd
biggest
like
challenge and what you've done to overcome it.
Yeah. So I'd actually like to build a bit on what Jonathan started.
Right.
So for me, it's kind of functioning seamlessly, and the way that I divide it is kind of clerical tasks and more of the procedural physical doing things. So in terms of clerical tasks, it's just been sometimes as much of a basic thing as ensuring that all the computers actually have a screen magnifier on them, be it Windows magnifier, and that actually informed my choice of where I was based in my residency. I needed to be somewhere where there was actually that easy integratability of screen magnifiers, which the university was actually helpful with me on that point. Unfortunately, in the system in which I work, there is still a fair bit of handwritten charting, which is very annoying, and which is why anybody who knows me knows that I carry around two portable CCTVs with me so that I can charge one so that I can use the second one after I've depleted the first one. I carry a lot of gear around with me, as we'll get to it a bit. Um, when I took on more of a senior role in internal medicine before starting cardiology, I would often tell my junior residents and medical students, okay, you have to tell me, like, I'm not going to be able to read your note. Like, you need to tell me, or I will be able to read your note, but you will not be able to read your note at the same time as me because of how big I've made it. So it's really just being comfortable enough with myself, and also being able to have that trust with my team members of, hey, they're going to tell me what they actually wrote, which unfortunately you find out who you can and you cannot trust, but that's another story. And definitely something that I learned. Now, in terms of the more procedural things, I am a self-professed adrenaline junkie, and I actually very much enjoy doing procedures, even though my eyesight is very terrible. So what I now do, because I have now reached the age where I actually need to wear reading glasses, is I will have my reading glasses low, and then I will put my huge Beecher telescopes on top with a reading cap, and I'll have one lens focused at distance, because like oftentimes I'm putting in central lines or doing arterial access, and I need to look at a screen that's further away. And then I'll have one telescope focused for close, for actual fine manipulation with my hands. And then I'll have the reading glasses as well for my more general movement around. And that's kind of been the system that I have perfected over the past few months. It's worked for my catheterization rotation, like the interventional cardiology. I have also used it when I have been scanning for ultrasound, because unfortunately our ultrasound machines do not have screen magnification capabilities, and the typeface, God bless Philips. Sorry, there's no commercial, by the way, full disclosure, nothing commercial here. The font size is so bloody small on the ultrasound machines that, like, I'm surprised that normally sighted people can actually see this. But so I'm there again with my big Beecher telescopes looking at the ultrasound screen. It's actually entertaining for the patients, and it's a good source of discussion. Um, and it actually works well. So I've been happy that I've been able to kind of muddle through the messes and constantly, like, iteratively with my optometrist, try to think of other solutions for the technical challenges that come up.
Right. And it sounds like the visual aids have really helped you. And
Yeah,
just for people that aren't familiar with some of the procedures, I mean, you're literally putting a catheter into someone's
someone's
neck
neck.
vein,
Yeah.
threading it through, and some pretty high intensity stuff for an adrenaline junkie. Uh, Megan,
I will
challenges and what
challenges
you've
and
found.
solutions. Yeah.
Yeah.
I'll go through very briefly two of the biggest challenges I had during my medical training. The first was just the sheer number of standardized tests that we take as doctors in training, and then finally out of training. I had no idea when I entered this profession how extensive this was going to be. And these tests are not like 1 or 2 hours long. They're 6 to 8 hours long without accommodations, and I get time and a half. So it's often split over 2 days. Not always, but often. You take the MCAT, and then in medical school, you take 3 standardized tests. They are called step 1, 2, and 3. Once you get to residency, every year you take an in-training exam to make sure that you're keeping up with the material and you are learning appropriately. I did a combined residency, so I took 2 ITEs per year for 4 years. Then I got to fellowship, and I dropped back down to 1 ITE for 2 years. And then at the end of all of that, you take your boards, and I took 3 board exams. So that's like, it added up to, like, I don't know, in between 10 and 20 tests. And they are grueling and they are awful. And I didn't do very well on the first few. And the reason for that is because I was studying just for content. I wasn't training my body for like pacing. Like, when I study for a long exam now, I know that I need to like train my eyes to look at a screen for a longer time than usual. And I also need to keep my concentration for longer. And then after all of that, then I need to actually learn the material in addition to that. And so that took a bit of a learning curve. Having accommodations in place was also very helpful. And once I was able to do that, I didn't get them for the MCAT, but I got them for step one. After a very pushy ophthalmologist told me that I needed them, and she was totally right. And then, you know, subsequently, I had those accommodations, and that helped a lot. The second challenge I had was I feel like medical school was definitely the hardest part of my medical training. And it was particularly the transition from second year to third year. So for very briefly, for people who are not aware of how medical school is structured, the first 2 years in general are more didactic. It's kind of like, I think of it as like university or college on steroids. You're kind of in didactic class most of the time, and it's definitely more rigorous than college was, but the way that you learn is pretty similar. But that's contrasted to the second 2 years, where you're actually, for the very first time, stepping into the hospital. You're learning the hospital culture, you're learning how people practice medicine, and it's almost like you are learning a new language and learning new customs. And it's very difficult to do that sometimes, day to day, picking up these new customs and things like that when you have a visual impairment. And so I had a lot of anxiety going into those 2 years because I just felt like it was so unknown and I didn't really know what was going on. And once I got there, I was right. It was crazy and chaotic. And very briefly, for the last 2 years, in general, medical students will change their rotations every 4 to 8 weeks. So every 4 to 8 weeks, you're entering a new world with new people. They do things totally different. The medicine is totally different. The patients are totally different. It's maybe a different hospital in a different part of the city. And it gets really overwhelming. And it was just time and giving myself some grace when I really wasn't very good at it for the first few times. And that is okay because I kept at it. And by the end of medical school, I was feeling a lot more confident. You know, when you get to a residency, you're in more of your own environment that you chose, the field that you chose to do. And then, you know, in fellowship, it was even more my field. Like, you just kind of keep going up and up and up. You get more and more and more knowledge, and you get more and more comfortable.
Nice, nice. Yeah. All right, great. Ettore.
Well, I think for me it's a bit of a slightly different experience because obviously I remember to everyone I started my medical school in 1975. So in 1975 we didn't have any computer aid at all. So what I basically I had in me was just a magnifier and that's all. And sometimes enlarged photocopies of books or enlarged, notes. That was the best I could get at the time in terms of adaptation. So, and also very important maybe for people to understand, I decided that I want to do medicine a few years before when I was just 16, mostly because I was intrigued by the interface between being a person with visual impairment. I was very curious about if the challenge, the emotional difficulty that I was going through were part of my nature or were part of my nurture. So is it because I don't see properly that I have these emotional difficulties, or is it because instead people around me treat me in a slightly different way? Because that's I don't want to take away the important component of our emotion and the way we feel, even when we decide to challenge ourselves in something that is quite challenging. Second part was obviously, and as Megan described, yes, the first 2-3 years were college on steroids. Even for me, a lot of science, basic science, a lot of knowledge that I was not always familiar, but you have to get into that. And then, obviously, the biggest challenge was to go into the clinical component. That, again, as Megan described, it was this rotation going to different places, general medicine, emergency department. At that time, I must admit, in my period, you have only few compulsory rotation, and was more freedom to choose depending on what you wanted to do. I basically pick and choose the rotation that were more familiar and I could handle easier with my visual impairment. So I avoided completely all the surgical ones. And I was allowed to mostly to spend my time between psychiatry, pediatrics, especially and immunology, lab, and all that. But then obviously, and this is interesting because when you got into the fellowship, you get completely absorbed in your field of interest. So for me, when I just finished my medical degree, the challenge was to get my license. But then once I get my license, I basically felt I was practicing and working in an environment that was familiar to me. It was about talking to people, recording, understanding where they're coming from, a lot of psychotherapy, a lot of self-reflection, and so on. Interestingly, going across my career, computer became a reality in 1984, but they still were limited. So the big change was when in the early 90s, I started to use a computer already in my day-to-day practice. And again, as everyone has reported, Jack, reading notes, that has been the major challenge. Majority of the hospital were all paper-based. There was no DMR. There was no electronic data record. And then obviously, some people were very kind to me. Some nurses were very kind to read for me the notes, or they were supportive. I must admit, I've been blessed also to build a good relationship with all my colleagues and making them understand that I was a value actually for them, because I was able to process more information and using more my ability to read with my mind more than my eyes. And that's another point. Interestingly, in my career, obviously, I challenged myself in different environment, different place, but also I took the challenge to work, and that's important for you to understand, in a different country, in a different language, in a different culture. And that's gave me a boost in my confidence, because I start to realize that people, human, are all the same, no matter what language they speak. And medicine is a very much an universal language. And yes, there are cultural differences, but that was a major boost of my confidence. And I became more and more interested in translational medicine, all the aspect of that. And then obviously I challenged myself to move from England, where I was already, having a good experience and a lot of support, to move to Australia. So all that obviously has changed. And now my major desire is to transfer and to help all my junior colleagues to thrive, and having more and more people who also have similar challenge like the one I had. But also I feel a very strong advocacy for anyone who has any disability, because I worked mostly with people with disability, any kind of disability, intellectual, physical, sensory, and so on. And that opened my heart and my mind also to work with very, anyone who may have a challenge in their professional life.
Great, thank you. It's
Yeah.
Rory.
Would I be able to
So,
add a couple more?
oh yeah, sure.
Yeah, I just wanted to
Please.
kind of just touch on two things. And I think maybe a question about disclosure might come up later, but just saying that when you're going through those many clinical sites and rotations, I think one of the greatest challenges that was just brought up about having to meet new people all the time is the fact that you then have to figure out when you're going to tell someone about the things you need, how you're going to tell them, if you're going to tell them. I think that there's so much calculus involved in figuring that out. And as Megan mentioned, that can feel really overwhelming and really stressful. So I guess a solution to that stress is definitely finding people, and whether it's mentors or friends or potentially family members that can just listen to that stress and try to help you figure out what's your spiel going to be when you talk to people, um, and kind of build that confidence in talking about your needs. I think that that's something that I'm not the best at yet. I'm still figuring it out myself. And but yeah, I think just one other technical thing that I wanted to touch on too is surgical skills. Actually coming into medical school, I was really like having already like internal conflicts because I was, um, I guess, really attracted to the idea of surgery, because I've been like using my hands to do things for my whole life. Like whether it's like building things or artwork, um, and I felt like I had the dexterity to do these skills, and I was like concerned about the visual aspects of things. And I guess what I would describe is that I actually have transitioned away from that interest for many reasons, and I think part of that reason is I kind of figured out what my level of resilience was, and that's a personal choice. For me, I know that I'm a very resilient person. One, I've gone, into medical school. I've done many things, and also dealing with a visual impairment while doing all those things. And I know that the panelists are also incredibly resilient people and doing, their various activities as well. And I'm sure that the folks in the audience are as well. And I felt as though the amount of effort that I would need to put into becoming a quality surgeon, um, was an amount of effort that I felt like wasn't worth it to me at the end of the day. And once again, I'm saying that that is a personal choice. I think that what I'll tell you all about some of the things that I was doing in the OR to kind of adapt my vision to the operating room. But yeah, at the end of the day, it really is going to be a personal choice of how much fight do you want to put into this. Um, I One of the main difficulties was figuring out suturing, um, and that's the process of at the end of a surgery when someone has their skin cut, closing the skin to allow healing of that skin and to enable just the wound that's you've created underneath, and also the wound that you've created in the skin to heal properly. And for me, there was challenges with knowing, where the needle was, figuring out the angle that it was exiting the skin from. There's many like technical things that surgeons are kind of thinking about that they've adapted or not adapted to, but have learned to do over a long period of time of doing it. Um, and I think your body positioning as well during surgery were all things that I was facing. As someone that loves to bring things close to their face, it became a conversation a lot of the time where surgeons were like, stand up straight, like don't have your head down, or you're bending too far. and it was
I
it
gotta
was
see.
challenging because yeah, it was challenging because like in order for me to do a good job, I was trying to do the things that I would normally do to allow myself to do a good job. um And yeah, it definitely was one where I was feeling bad about myself during those moments, even though I knew that I was trying my best. Mm. And the major tool that I was using in surgery are these things called surgical loops, which are eyeglasses. I think they've gotten to be a little bit thinner, but they're usually a little bit on the thicker side. And they have two magnifying glasses. I think that that's also a conversation as well. Two magnifying glasses, usually placed on the lower part of the visual field. Um, and they range from magnification of like 1.5 to I believe like 3.5. And I ended up getting, I think also another conversation is I wasn't able to be sponsored to get this, but I purchased 2.5 x magnification on my surgical loops. They also have, it's called Designs for Vision, is the company that is pretty big in making this product. But they also have a 3.5 that actually has a larger visual field that it creates for you. Yeah, and so I was using those because I felt as though that would bring the image closer to me so that I could be a little bit further away, um, and try to perform these skills. And I think that one of the biggest things is that oftentimes medical students aren't expected to be using surgical loops. It's kind of an odd thing for attendings to see that. And I think that that was a tough conversation to continuously have with new people every day about, this is what I need to do my best. Um, and I think what I found through that experience is two things. One, for me, my like null point, kind of like where my eyes are oscillating the least, is when I'm looking up. So looking down through the surgical loops actually wasn't so advantageous for me. There is a surgical loop that has it higher up in your visual field. There is one. Um, However, I felt like the decision to get that actually, it kind of, for me, it felt like it would interrupt all the other things that are happening in the OR, like the many screens and understanding like where your arms are and in relation to the patient. But yeah, I think where the magnifying glasses were on the actual lens themselves, and the other is that the OR is very bright, and when you're looking through a very small magnified lens that's also very bright, it for me it actually did kind of just like affect me after leaving the OR. Like I felt a little dizzy, and um, there was one time that I was part of a 6 hour long surgery, and at the end of it, given the opportunity to practice suturing, and I was not feeling well at all after doing that, because for a longer skin repair, it felt as though I was really trying to concentrate on what I was doing, and that kind of led me to feeling dizzy, to kind of like have these floaters. And there was kind of a series of those moments where I felt like I'm practicing so much outside of the OR. I'm putting in a lot of energy, within the OR to make sure that I'm doing this right. That I felt as though it wasn't going to be the right decision to do that during residency, where I'm going to be working over 80 hours a week and still wanting to like practice these skills outside of the kind of hospital time.
Make-
So yeah,
Makes
I just
makes
wanted to add
sense.
I have a quick comment, if
Mm.
I can intersect. It's interesting because I want to share my experience. Obviously, I stay away mostly of the surgical area, but interestingly, my only small experience in this field was actually, and this you would say that's crazy, to follow some of the ophthalmology, where instead most of the ophthalmologists, they work with magnifier, they use microscope, they are basically already working with
It's common
a
for
high
them to be
level of,
wearing these devices.
yes, or even working toward a microscope, where they have to learn how to suture, not with their hands, but with basically with external tools. that are managed by by an interface. And again, similar to that, I would say this is now reality. Many operating theater are having robots, and robots is another story. It's like a video game, because it's like you are on a joystick and some other tools, but you are not directly your hand. So that's another ball of game. And I think technology is changing medicine, and in a way, I would say definitely from the time I trained to the time I see now my junior doctor, I think accessibility has increased. What has not changed instead, and I want to touch briefly, is instead the attitude, the emotional component. And that's something that I think everyone in this room has experienced in one way or in another, where having a doctor or having a trainee or a colleague that may disclose some limitation is unfortunately seen often as a weak component of the team, or someone that you have to carry the weight, or how do you handle that? So that's impose also a big cultural shift in how
Yeah,
do we
maybe.
accept.
Yeah, you bring up a really important point, and I think this has come up a couple of times. And so maybe Megan and Jack, um, how do you go about disclosing your vision, and how, like, how did you do that in talking both with colleagues and or superiors, and then also with patients?
Jack, you go
So,
ahead and I'll go after you.
Okay, so I'll tell you that I've actually had the pendulum be on both sides, and now I'd say it's somewhere in the middle. So when I was a medical student, there was one rotation in particular where my supervisors forced me to disclose to every single patient that I saw. And it felt kind of weird because sometimes it just wasn't relevant, where I'm like, I'm not like suturing something tiny here where I'm gonna be like 2 inches away from you. It's like if I'm talking to you, you don't really need to know. Um, Sometimes I would get questions from patients, in which case I would answer. And then there would also be some times where I didn't tell anyone until, like, unless I anticipated there was going to be a major issue, in which case I said, okay, so here are my visual limitations. Here is what I will do to mitigate, and I welcome any help that you have to give me, to maybe try to make certain things easier and to allow me to figure out, because my starting position is always I want to try to do everything that my normally sighted peers are doing, even if it's slightly differently, and even if I have to make certain adjustments within the realm of what is possible to make it happen. Now, I think that I'm a bit more proactive. So, like for instance, this month I'm in interventional cardiology, which is actually the rotation that I was the most scared of, because of the small detailed nature of the work. So this is like really putting the stents into people's arteries, like tiny arteries, a couple of millimeters. And on the first day, I went to the staff and I said, okay, so here's what my eyesight is like. Here's what I'm going to use. For the first few cases, if it's okay with you, I want to watch more just to get a sense for what's going on. And they were very helpful. They had actually thanked me for being proactive. It's not a sign of weakness, and in fact, it lets people know that you have a lot of insight and a lot of maturity to be able to say, okay, here is what I'm going to need to do, and to always leave it open to them of like, hey, I'd appreciate any help. And like most people are good people. I mean, you're gonna get a couple of bad apples here and there, but really most people, when they see that you're showing up to learn and that you know that you have challenges, they want to help. And that's the thing that I've actually been very appreciative for.
Megan?
Yeah.
Do you tell people? How do you tell them?
So I will say that I will typically not disclose that I have albinism to patients. I would say maybe a handful of patients have brought it up over the years, in which case I say just something really short and sweet. I have a visual impairment, but I don't think this is going to affect your care for this, and this reason. I do, however, remember one time I was a resident, so I was a training doctor, and I happened to be in breast cancer clinic that day. It was my very first day in that clinic, and I saw a patient with her daughter. She had had breast cancer for several years. She was in remission at that point. And I always take notes. It's how I help remember things. And so I was taking my notes as I was asking them some questions. And I actually didn't realize this until somebody told me while I was in med school, actually. But I think a lot of people with albinism do this. When you're focusing on something, we like kind of turn our heads a little bit without realizing it, kind of like shaking back and forth very slowly. I had no idea I did that until somebody mentioned it. And so, anyways, I was taking notes and I was like doing my head shaking thing, I guess, because the daughter said, "Why are you shaking your head? Is this really bad? Is my mom's cancer back?" And I was like, "Oh, like I think all the color drained out of my face." I was like, "No, no, no. Like you don't understand. I don't know anything." So don't worry about that. I am just taking notes. I have this visual impairment. It would kind of divulge fast. She obviously was not very trusting of me after I came back with the attending, which is totally fine. Like I never saw them again. But that one experience stands out in my mind as something that went badly. But fortunately, all of the other experiences have gone well. And patients are pretty understanding too, once they see how good of a doctor you are, you know. Um, with colleagues, I actually have found that it was much more important for me to tell people when I was in particularly the earlier stages of my training, medical school and residency. It was just much more important. As Jonathan alluded to, you're kind of like the furthest away from the action. And so you just need more help to figure out what's going on. And, you know, it's hard to just when you're used to bringing things close to your face and you're the one who's like 3 or 4 people away from where whatever's happening, the computer screen, the procedure, whatever, you just need a little bit more help, a little bit, somebody a bit more powerful than you, making an effort to bring you into the fold. And now that I'm an attending, I run the show. I'm the boss, and I forget to tell people all the time. Except for when I'm in lectures. I have really made a point to, and I would love to try and do this whenever I work with learners, just to kind of like, um, pay it forward. But, so many disabilities are invisible, including visual impairments. And so at the beginning of every lecture, without fail, even if it's like I feel awkward or weird about it, I say, hey, I have a visual impairment, make a little joke. If you raise your hand and I don't see you, just please like resort to heckling. That usually gets a laugh. Um, and then actually after one of my lectures, somebody came up to me and said, I have albinism too, and I have like never met anybody with albinism before. He's a college student, he's interested in medicine. It was just like very cool to do that. And so I do make myself disclose more and more now, even though it's not as important in my daily life.
That's a nice experience. So I would say, if I think earlier in my career and, in training, to colleagues or bosses, so to speak, I would disclose when a situation would come up. And surgical rotations, like when you rotate through the surgery area, that was a particular place. And I think what I found an effective strategy was, look, I want to learn everything I can about surgery. I'm just not going to be like the best at doing the actual procedures, but surgery is really a field of medicine to know, when someone needs to have surgery or not, what's the right type of surgery, all of that. I'm willing to work extra, to make up because what I was very mindful of is not for people to think, and this is something I think we've all talked about in the past, to think you're trying to get out of something. Like we're not trying to take the easy way out here, right? We're willing to do the work. We just need some accommodations, and I think that has really helped. Um, then with patients, um, early on, particularly like drawing blood, I would get like very close to do it. And they'd be like, "You sure you know what you're doing? What's going on?" And I would just say, "Hey, I just, I have bad vision. I just need to get really close." And I think the key is the more confidence you project, the less they're going to feel uncomfortable. And, the vast majority of times you just do that. Now, as a more senior person, um, you know, I'm at the computer screen like this, and I don't even mention it. And I know all my patients know it. I have patients that have been with me for many years. We just don't talk about it. They know it. They don't seem to bring it up, and anything else. The other thing I'll say that Megan you brought up is, I've in sort of my different roles, I've had a lot of sort of like giving lectures in front of large groups and that kind of stuff. And particularly when it's time for questions, I'll do something similar. Say, hey, unless you're really like, doing this, I'm not going to know that you have your hand raised. So yell out or, do something, or have a colleague say, hey, do you mind, calling out the questions as they come out, and that's gone very well. Um, so we're gonna move to questions in a little bit. So put your questions in the chat. Um, maybe I will, just quick answers so that we have time for all of the questions that well, here's something that I think would be worth talking about. And maybe Ettore, you could talk a little bit about this. So, we're, people with albinism that, have a visual impairment. Uh, but there's a broader category of physicians with various disabilities. And there's a Stanford Medical Alliance for Disabilities that may be a great resource for many of you to check into. Tori, do you want to talk a little bit about them? Because I think that's worth people
Yeah,
knowing about.
that's a very important initiative that has been established in Stanford, and they have a series of events, including also there is a mutual mentorship program that they run, where there are open group, and obviously they welcome and support people, doctors with any or not only doctors, allied health professionals with any kind of disability. The focus has been on at least of number one, what in some way may help in the learning and training environment, because that's very important part. Majority of people who get into medical school have a challenge, but also in the work environment. And again, visual impairment of being a doctor with albinism is only one of the many disabilities. There are more and more clinicians that may get impaired during their career due to a condition that they may achieve, physical impairment, paraplegia. There are doctors who have, but also very important to ascertain how in the medical profession, having, for example, neurodiversity or being neurodivergent as play a role, an important role. So all that take into account what makes a good doctor in some way, I would say. And how do we navigate as a medical professional who have our own disability, our own impairment, our ability to enhance instead and support people who have similar. I personally, I did a podcast for the College of Psychiatrists here in Australia, where actually we share the experience of being a psychiatrist and a trainee in psychiatry, how this impact in your day-to-day work and how you can develop. And this is something that I think that Jack has and Megan have. How do you develop this, the soft skill that are actually core in the medical profession? Because again, we may struggle to do a suture, we may struggle to do a cannula, but definitely our visual impairment help to shape a better, I call the internal eye of the man. You see with you watch with your eyes, but you see with your brain, and that's an important point that I make all the time. So I've done things that probably were a bit of a risk for me, and I like how Jonathan share his and Jack there being adrenaline junkie, but at the same time you develop another part of you that help you to navigate in when you don't have a lot of information. That's an important component, and I'm glad that we have in the audience people like Chuck Huss, who has done a fantastic job for all the people who want to have a driver license, but also this important aspect. What do we see? It's the core component. We know that not having central vision has some limitation, but having peripheral vision actually bring a lot of other opportunity to watch the world in a more holistic way.
And I would just add, in terms of the Stanford group, um, you know, what we're all talking about here is a microcosm of a movement that's happening in medicine to really recognize the value of physicians with disabilities. And I think the good news there is that accommodations are more and more common for more and more reasons, and it's less of a lone wolf kind of thing where we have more voices. We have more ability to sort of make change. Um, I think I'll ask you each if you want to just very briefly, um, you know, a sentence or two, just because I know we've got a boatload of questions, and I appreciate that everyone is so engaged. Um, if you could offer one piece of advice to the audience here of perhaps people that are thinking about medicine as a career or have a loved one that is with albinism, and so maybe Jonathan, start with you.
Yeah. Honestly, the best piece of advice that I can give is to seek out community and mentors. Um, That's been the biggest help for me. Whether it is connecting with the dean of your medical school or whatever institution that you're at to find out if there's anyone that's visually impaired. Now you have a community with us, um, and I think that connecting with the Stanford group as well, finding that community.
Excellent. Jack.
If it's okay with you, Bob, I actually wanted to build as well a bit on something that Victoria had said. So I think that medicine requires a lot of perspective, like a lot of different perspectives, and sometimes, and we need a lot of out of the box thinking. And I find that people with disabilities, because we're so conditioned to interact with the world in a bit of a different way, it gives us a very unique perspective. And it also gives us insight into the real struggle that the patients have in front of us. And I think that it gives a lot of empathy. So, in terms of the advice that I would give to anybody who's interested, first of all, don't get discouraged. There are going to be a lot of bumps in the road, but also don't be afraid to think out of the box. And exactly as Jonathan had said, you're not alone. There are a bunch of us here just like you. who have gone through the same problems that you are going through and the same struggles, and we've made it through. So take strength from that and don't hesitate to reach out.
Excellent. Ettore.
Well, I would like to use a quote that is not my word, but is a quote that I use all the time when I talk about this, because I think that has been my internal motto when I discovered that this is, I'm quoting Steve Jobs. He used to say, stay hungry, stay foolish. You know, this is the most important part of all of us. It's about celebrating our uniqueness, but at the same time stay curious, be on top of everything, because that will help you to navigate even the moment where you feel you struggle and everything is difficult, goes against your wish. And very important, but that's take your advice as a psychiatrist, be always self-centered. So be able to read inside yourself what are your drivers, what make you feel motivated, because that's a very self-reflection is extremely important, no matter what you will do, even if you are a surgeon.
Very good. Megan.
My piece of advice is something that I now give to anybody who approaches me that's interested in medicine, but I think for someone with albinism, it's more important to do this. And it's what I'll say is I will never dissuade anybody from entering medicine, but I'm a big believer in informed consent. And speaking for myself, I did not understand what this was going to be like when I applied for medical school and got in. I did not spend enough time talking to people. I didn't ask anybody what the worst part of their day was or what their training was like. I didn't ask people the kind of sacrifices they made. And I think I would do it again, but I made a lot of sacrifices. I do have really bad parts of my day sometimes, and certainly I did in training too. And so I really think everybody should owes it to themselves to really try and talk to as many people as they can to really get a good idea of what their lives are like in the profession that they want to enter.
I think that's good no matter what you're going into. Yeah, that's great. I would build on that as a you know, I first of all, I mean, medicine is a challenging field for anybody. And that's just the reality. And so first and foremost has to be something that you're really passionate about, that you really love, because again, forget about albinism, just anybody going through the process, it's intense. And so it's got to be something that you're highly motivated to do. Um, as you heard, you're taking tests all the time, and it's a lot of schooling and a lot of training. So you have to love that. You have to appreciate the journey. It's important to have support um, from loved ones where possible, from mentors. I think all of us, I suspect, if we had time, could talk about stories where it was the kindness of mentors that really helped us along the way during a difficult time. And I think that's really important. Getting getting an understanding of what it'll be like by shadowing, depending, when you're in college, for example, there are opportunities to shadow in a clinic and be able to see what it's like and play with some of the tools and those kinds of things. And I think, overall, the most important thing is, um, yeah, clearly all of these people here demonstrate that it's possible to be a doctor with albinism. And you know that that's not something that everyone realizes, but it is possible, and all of us here are proof positive of that. um, So Casey, I
Oh,
know we have like a ton of questions, so
Yeah.
can I say one thing only just to
yeah.
close? Also, be open, Bob, you said, a long life learning, but also watch this space, because we are in December doing a webinar about AI for visually impaired people. This is an area that everyone, not only if you want to be a doctor, that is a reality that people should start to consider as a tool to enhance your ability to fulfill learning, but also exploring everyday aspects. So watch this space. There will be an announcement from Noah.
Right.
Thank you. Yeah, so we do have a lot of questions. A lot of them were pretty much covered, though, I will say. And we're not going to take up too much of everybody's time tonight. A lot of these have already been kind of covered, but I have seen, we did get a question before this call ever started. We asked people to send in questions, and we did get a question, and I hope I didn't miss it if we did mention this. I don't think we did. How do you manage, someone said, how do you manage transportation in your career? And then Chuck in the chat also asked up toward the top. I'm gonna have to find it. Chuck asked something about, I can't find the comment, but it was about if any of you are licensed drivers. Oh, here it is. Wait, nope. I don't know if it got pushed to the bottom. Oh, here. How many of the
Yeah, look a
speakers are
little bit
legally
further
licensed
down.
drivers? Has a driver's license made a difference in your practice as a doctor? So yeah, just transportation, driving, if anyone wants to touch on that. I see some of you actually already answered in the chat, it looks like. Actually, all of you almost. Looks like you answered him. But if anyone wants to just touch on that.
Multitasker. So does someone want to share a little bit about that?
I drove for nearly 10 years, but not meeting all the standards. It was a bit of a risky business, and then I decided that I didn't want to do it anymore. And that's I was driving in Italy. That is even more challenging than US, I would say. But I'm 636. That's my visual acuity, so I'm probably not a legally blind person. That's my understanding. But now I wouldn't drive. I mostly, my life has been in a big city where there is good transportation, and I've been lucky to live in London, and here in Perth is a good transport network. But Uber now makes a difference, and maybe Waymo or whatever is the self-driving car. I'm actually, I went on a test drive of a self-driving Tesla, and I think that we are nearly there. Why do I need to drive?
For anybody who's wondering, I was not familiar with 636 vision. I think of it more in like 20 blank. And so I Googled it. It's 2120 is 636 vision.
Non-metric
Oh yes,
world.
because every country different way of measuring.
Yeah.
And I would say, I lived in urban places for, most of my life, and then, mass transit was doable. I did live in a more rural area, and then I actually put like an ad in the newspaper for a driver, uh, and uh, and that worked. And now, of course, Uber, Lyft, and all of those options make a big difference. Yeah, I mean they're game changers.
Awesome. It looks like a lot of you have actually, during this call, have done an incredible job about getting everybody's questions in the chat already. So that's really great. And then Chuck, I'm looking over these questions that we got, and I'm looking at them and I think a lot of this was covered. What do you think? If anyone has another question, you can feel free to put it in the chat. We have a little bit more time. But I'm
Yeah, if
looking
someone
and
wants to come on camera,
yeah,
even
yeah.
and
If you want to even come
ask
on
a question.
camera, get off of mute. If you want to ask a question verbally, that's fine too. To our panelists.
This is Wes with the hand up.
Uh-huh.
Hey,
Wes, you can go
Wes.
ahead.
Yeah, are there any doctors with albinism in the Portland, Oregon area?
Ooh, not that we're aware of, but the reality is we don't know all the doctors with albinism. We only know the ones that have sort of joined this group. But I wouldn't be surprised. Are you looking to relate to someone locally as opposed to,
Yeah, locally. Yeah.
uh, anyone aware of anyone?
Just I would
And
ask.
yeah, and then of course, through Zoom and stuff like that, there can still be, you can reach out to other folks. But yeah, not aware. But the numbers are increasing, that's for sure. Because I said when I started, I didn't know a single person, and now there's a bunch of us.
Awesome. Thank you, Wes. Anyone else?
Thank you.
Looks like we don't. Can
So,
I?
Oh,
Oh, go ahead.
one thing.
while I think in the chat we kind of established that there's no minimum visual requirement, I thought it might be good to add that there are technical standards for medical school that everybody has to meet in order to graduate. They typically include things like observation, communication, some aspect of motor skills, and intellectual abilities, and professionalism. And there are prerequisite. Basically, you have to be able to do all the jobs that the doctor of your field can do in order to graduate. And you do have to attest that you meet these technical standards in order to graduate or even apply, I think.
I can add also one aspect that, for example, apply at least my registration, my license here in Australia. I don't know in the US how does it work, but in Australia and UK, you may have license with condition, and condition are, for example, that I will not practice surgery or surgical procedure. Again, condition are basically limitation on what you can do safely and without any problem, and they don't limit your ability, because one thing that we have in medicine, especially when you are practicing for some years, is your scope of practice, what you are familiar. So usually if you are a surgeon, you have a scope of practice that is about performing certain surgery. If you are a physician, you should be able to perform certain activity. But if you are a psychiatrist, that's the different story. So the scope of practice really clarify the limits that you have to perform, and what instead you actively engage yourself on not performing practice that may put yourself at risk and others in the public at risk. That's the very important to say. So it's based on what you disclose to the medical board, and unless you are doing something that you may be responsible and you haven't disclosed your limitation, that's where you may get into trouble. But you can say, I will not perform any surgical procedure. I will not perform things that are outside of my scope of practice.
We do have two more questions in the chat. Zoe P says, do accommodations carry over from high school and college to med school?
I don't think I have like the best answer to this question, but I'll kind of provide my response though. Because medical school was actually the first time where I established official accommodations. I think that has to do with kind of the familial culture around albinism for me, and things like that. But within medical school, it definitely was a really good process. of like having my requests respected, and I think that having them implemented was a little bit of a challenge. I think that there's certain things that people just aren't used to doing, whether it is, you know, simple things like providing like Zoom links so that I'm able to interact with the lecturer, even despite any physical location that I'm in, within the classroom, doing things like enlarging font or enlarging the cursor size, changing the color of the cursor, and things like that. And I think for me also having that conversation, it was the first time that the disability counselor within my medical school was like having a conversation with someone that was visually impaired. So I think that that in itself came with its own complications. So thank you so much for asking this question. And if you do have accommodations from high school and college, I think that it would really inform the things that you'll be using in medical school. There are certain things um, that will require different adaptations. So things like, you know, a cadaver lab or any other sort of like technical skills, like Bob had talked about blood draws and things like that. I think that those will require a little bit more thought. And honestly, when you asked this question, I was actually had an idea because when I was developing my request for accommodations, I looked at a sheet that Noah had offered about elementary school kids. And I was actually just thinking that maybe we should just create a document for medical accommodations. I think that that could be really cool. So thank you for the question.
I also want to jump in and say, take this opportunity to start good record keeping, because when you apply for accommodations to take all of your standardized tests, your boards, etc., you're going to need to prove that you have the disability and that you've had accommodations before. So keep everything in one place, label it well, because you'll be referring to it often.
And the good thing, just with the American system, as Megan had mentioned earlier, there's so many exams. But for me, when I took my first step exam, the process of getting all of my documentation and accommodations was really grueling. And I think an emotionally taxing process. Unfortunately, when I was taking step two, that process was way simpler because I had already established the accommodations that I needed, and I wasn't asking for anything more at the time. So that was a smoother process. So, Megan, would you say that it continues being as smooth as you move forward? Or?
So much easier than the first time. Similarly, step one was the first time I got accommodations. The dean of my medical school said, you need to throw every piece of paper you have at these people because I don't know if you're going to get what you're asking for. So I had they asked for like records of your life. I had my mom send over IEPs from the third grade. I spent hours on this packet. But it was worth it. I got them. And hopefully, all of us going through these and getting accommodations for this type of visual impairment, my hope is that we're setting some sort of precedent for other people with albinism who are coming after us.
But yeah, just to add on, you do have to hand over an arm and a leg. Like I remember I actually had to, so even though I'm in Canada, I wrote MCAT and I wrote step one, step two. So I remember having to get my high school principal, who was still working at my high school, to write a letter that I had actually received accommodations for our provincial standardized testing. And like I had to give them my high school transcript as well. But like the more information, and like yes, it feels invasive, but again, as Megan had said, the more information you give them, the more likely you are to get what you need.
I just want to add on this matter that's obviously, I'm in a different stage of my career, but what we are trying to implement, because I'm also sitting in a disability and inclusion committee of my employer, that is a health authority here in Australia. And we are basically supporting most of the people who have any disability to not to be in some way mandate to share all the documentation, but only what is relevant and specific to the specific adjustment and accommodation. Also, there are, again, that's not US, but in Australia, every employer has a duty to provide accommodation to their employee and to make sure that they have the best. So there are actually organizations that provide a work assessment and they suggest the adjustment to the workplace because it's an occupational health and safety concern as well, because no one wants that you get injured at work. So there are also these are the protection from the employment that are making more and more easier to getting accommodation in your workplace, like magnifier. So for example, I have my desk has two 32-inch screen. I have my magnifying software. This has been paid by, obviously, by a government-funded support for the employment.
Excellent. Oh, go
sorry.
ahead. I was just going to say, I think we have maybe time for one last quick question.
Yeah, I see Kim's hand is raised, so I didn't want to miss
Yes.
that. Kim, do you have a question?
Hi there. Yes, my name's Kim Avila. I am a professor and I have a PhD in disability research and statistics. And I really appreciate the discussion about the accommodations. I also want to really reiterate that in our advocacy efforts, advocating for accessibility standards and inclusion of like WCAG principles and those guidelines are really instrumental. I just went to my hospital center the other day to check in. They have the Epic kiosks. They're brand new. They were completely inaccessible to me as a patient with low vision. And my husband is on the WCAG standard setting committee, and he is a 508 and accessibility specialist. And he said Epic is notoriously inaccessible and has posed a lot of problems with getting the things integrated. And we're thinking about this from the low vision perspective. You all were mentioning charting using the ultrasound machines and the companies that create those. So there are standards for making those devices and computer programs accessible. And this isn't limited to just us. There are so many people who have, and I think Dr. Garcia mentioned it, that have other disabilities, that they have dyslexia, they have visual processing, and they are medical doctors. They are brilliant people, but they benefit from those accessibility standards as well. And so our advocacy, in addition to requesting accommodations, also needs to go to the programmers, the companies that develop those software programs and all of those systems.
Great. Thank you for sharing that, Kim. I think we're run out of time. I want to thank all of our panelists that have demonstrated resilience and hopefully inspired you. And they're all really incredible physicians that are just doing a great job. So we're pleased to do this. We really thank NOAA for sponsoring this for us. This has been recorded, so if you know other people, friends, loved ones that might benefit from listening to this, I think the link's going to be sent out. So please take advantage of that and really appreciate you all joining. And Casey, I'll turn it back to you.
Yeah, thank you so much. I will be sending the link out via email, hopefully in the next day or two. So be on the lookout for that to anyone who is registered for this call. And thank you all so much for coming. You're always welcome back anytime. We love this group. So many amazing things were shared tonight. And thank you all for your time. Thank you to everyone who attended and for your great questions. And yeah, I hope you all have a great night. We'll see you soon.
Thanks, Casey.
Bye, everybody.
Thanks, everybody.